pretend this is the case. So, in all modesty, what I've tried to do for this talk, and as well as for the next talk, is just speak out of my own experience. I'm definitely not attempting to be totally comprehensive. I'll probably have skipped things that you will remind me of later during the interrogation sessions, but nonetheless, let's start and let's see how we can accomplish something. So, neck dissections, we've already discussed this. This is an ongoing topic of discussion in thyroid cancer treatment. But we all are aware of the fact that nodal metastases are a big time problem. We've just discussed a very interesting case of MTC, to operate or not to operate, and we do know it's a high incidence problem in both PTC and in MTC. As far as 2/3 of patients are concerned. So although particularly in PTC it does not really have any a potential prognostic implication, it does have large implications on quality of life, on trying to avoid morbidity. And what I've done for this presentation is go around the different levels of morbidity. What can we do wrong? Where we as surgeons could we cause morbidity? And this is the last thing we would like to do in cases of patients who will have an excellent prognosis, generally speaking. So it's important for local control, but it's also very important for quality of life. And as you know, the field of surgery for, we just heard Shelto's talk about the former topic, but there is a tendency worldwide to be less and less aggressive. However, having said that, it's very difficult if a patient comes into your office already charged with a diagnosis of cancer, with a lymph node, not to operate or not to do anything. And it generally takes much more time and more effort to persuade people not to undergo an operation than to let yourself be persuaded by the patient to do the operation. A neck dissection has evolved from doing a lot of things to doing much less. And at present, as you know, the classical radical dissection has been sort of abandoned in favor of the modified neck dissection, and nowadays we're even more selectively designating regions to operate in the neck, and with re-explorations we will just try and keep it as small as possible, doing node picking or level picking, basically, preferably under image guidance. Even if a node is palpable, I still would like a pre-op ultrasound to see exactly what's happening just the day of or the day before surgery. I've never regretted a decision to do that at any point in my career. And I still, and as you know, these are the levels again, but 2A, 3, 4, and 5B are basically in PTC what we would define as lateral neck dissections. And there's, of course, there's exceptions to that rule, but basically these are the locations, the levels that we will approach during lateral neck dissection for thyroid cancer. You know this illustration. It's very hard to see from here, but you can see, if I can see, you can see Erb's Point there, which is a phenomenal anatomical landmark if you can find it. In some cases, it may even be hard to find it, particularly with the habitus of the Western citizen, I must say. So, if you define the complications, these are probably the most prominent ones that I will discuss one after the others. And there's some very nice reviews, amongst others from Ashok Shaha in the Annals of Surgical Oncology. That's very worthwhile reading. So I will talk about these separate components, but I would like to emphasize first that there are cases that have increased risk of complications when doing lateral neck dissections, when doing surgical surgery per se. Obviously, prior radiotherapy or prior surgery to the neck or to the thyroid are risk factors to concern. We were just discussing if you have a small lesion in an already operated or reoperated neck, what are you going to do? You might as well wait until you're sure that it is A, the lesion you want to aim for, and B, that it's large enough so you can find it easier, so you can be more and more selective and avoid complications in that sense. And that's probably one of the most important tips that I have. Don't be too aggressive in lesions that are small. If you have redo surgery, post-irradiation, whatever kind of antecedents, that please be as careful and as withdrawing with your surgical hands as possible. On the other hand, you also have the fast-growing tumors and tumors with fixation. What do you do with encasement? In the next talk, I'll have two of these cases. But we discussed in the context of poorly differentiated carcinomas that it's sometimes very difficult to decide what to do and particularly what not to do. Another general consideration is that you need to take into account the whole patient and not only the neck and the thyroid cancer aspect, but realize that as far as you can optimize comorbidity. Many of those people will be smoking, and this is, of course, I don't have to emphasize how that affects general health and recovery post-op. And as I said last year also, prepare for the worst and hope for the best. This is also, if you prepare yourself, I'll refer to that later as well, you also prepare your patient for various outcomes and the decisions you might have to make during surgery, when you want to stop and when you will not stop. So scanning and planning, and obviously the team of the Netherlands has fallen back tremendously in soccer leagues, but we're getting back there and teaming up. Getting colleagues into the OR and doing things together is probably one of the biggest lessons in my career that has helped me greatly reduce stress levels of the one lonely surgeon being alone to a very much more balanced and pleasant way of doing very difficult surgery indeed. So I talked last year about Kylie, so I'll be very brief on that. It happens, and it happens more than we would like to think. Obviously, particularly on the left side, but not only on the left side. And you know the anatomy of the thoracic duct, or ducts, I should say, is very variable. But you have to be aware of that. And awareness is number one in tips of prevention. So you have to actively look for the duct. If you can't find it, look for leaking lymph. Look for leaking current. You can see it. And you should be very aggressive and not go out before it's really dry. And if you have a surrounding tissue to include into your suture, you should do so, and you have to add glue or patching. I'm not really fond of Tacocin patching in that region, particularly not to stop high leak or lymph leak. Blood is something else. But some histoacryl that we've seen in the boxes is very elegant way to cover if your suture alone is not really working well enough. And if a conservative therapy after operation fails, then don't hesitate and go back early instead of waiting for weeks if the conservative measures fail. Just go back and fix the problem, as you can see here with the glue on the left side picture, or the right side picture, sorry. So what about wound infection? The neck is generally very well vascularized, so wound infection per se is not really the biggest area of concern. But flat necrosis in cases of really extensive surgery should be something to consider. If you can avoid trifurcations, you should. And keep in mind that antibiotics do not avoid wound infections per se. And these are probably the curvilinear incisions, whichever you prefer. We generally take this one. I've known colleagues who will only divert to these incisions. They are nice to heal, but they're sometimes a nightmare if you want to be in all quadrants of the neck, as I just told you. You can choose your pick, but be sure not to use longitudinal large incisions. Hemorrhage is generally occurring early post-surgery, of course, and I don't have to mention that meticulous hemostasis is one, but it doesn't help you fix the problem in all cases. As opposed to with Kylie, I'm pretty liberal. We're liberal with Tachysil over large areas where you've done dissections, but not in the deep area, level 4, going into the thoracic cavity, level 5, all the way to the lateral side. It's very difficult to apply Tachysil there, so it won't help you. We do drain in large dissections, not in selective dissections. And of course, when you have an acute swelling and dyspnea, you should go back and fix the problem immediately. I've had a few cases in which the anesthetist was always later than the surgeon evacuating the hematoma just prior to anesthesia. It doesn't matter. You have to fix the problem first, and then you can do the anesthesia, etc. Later. Carotid blowout, you read about them. I have to be careful, but I've never witnessed one myself, so I'm not speaking out of expertise, so to speak. It carries a high mortality, and of course, again, post-irradiation, post-fistula necks are probably more at risk for this kind of extreme complication. We do not advise any form of artery resections in thyroid cancer cases. But you have these we were talking about debulking surgery for advanced cases. This is one thing to consider, and with the advent of all sorts of stenting techniques, you might consider in the really risky carotid shaving, so to speak, to apply stenting, although this is not there's no evidence at all for interventions like this. Now, internal jugular vein injury is a different thing, and as you know, in advanced cases, you can resect the internal jugular vein. If it happens, if there is an injury during surgery, it's probably, generally speaking, it's easy to fix. You just apply pressure, don't have the resident apply suction all the time, but just compress rather than suction, and control the vessel with Vesselers. You'll be out of trouble in no time. Generally, putting an Alice clamp over a venous defect will help you, and you can suture easily. But in any case, if you have to sacrifice the internal jugular vein, you shouldn't hesitate to do it. There is the old case of air embolism. I've witnessed a few, but they are very rare. But if you lose control of a situation like that, again, digitally compress the problem rather than apply whatever other exploration or try to find the hole. Just compress the problem. If you do not have extra hands, call in extra hands, etc., to fix the problem, and then tighten the effort loop as soon as you have control over that situation. If suspected, if the patient is really suspected for having air embolism, you have to put them in Trendelenburg and rotate them through the left side to at least ensure as much filling of the right heart as you possibly can achieve. Now, obviously, sensory nerves are to be cut in surgery. This is always the case, and I've been always astonished that people, they come back with huge incisions, not only in the neck but in the abdomen, and the only thing they complain of is a small area of hyposensitivity. And I always remind myself that the mistake that I have made then is not to warn them beforehand that this is the case, because they're not concerned per se, but they're concerned because they didn't know. So this is a good reminder for myself, at least, that I always try and focus. And listen, it's not terrible if you have a hyposensitive area for some. Generally, most of these hyposensitivity areas resolve in a couple of months, and if they do not resolve entirely, they will at least, patients will at least reach a balance in which they're not really bothered with it anymore. But just to mention it to a patient is probably the best tip to avoid problems later on. And of course, you have the greater auricular nerve with the earlobe hyposensitivity. It's not a big thing, but if you can avoid it by keeping down the nerve on the SCM, on the sternocleidomastoid muscle during the development of your flap, you're well off. And then sometimes it is unavoidable. Now, a very much more intriguing structure and a much more dangerous structure to injure is the marginal mandibular branch, of course, of the facial nerve, which particularly during high dissections, level 1, level 2, level 1 generally is not involved in thyroid cancer, level 2 definitely is, and we all come back there. And this is probably the nerve that makes us a little bit apprehensive in that region. But it does lie below the cervical fascia, so you might need, you want to see the edge of the mouth during draping, and during the operation you do not want an anesthetist to totally relax the patient, and you want to be able to use nerve monitoring whenever available and essential for you. And if you cannot easily find it, or you definitely want to move on, it's very good trick to just divide the facial vessels, the artery and the vein, which you can always easily find, as deep as you can, and then just preserve the stumps on the cranial side, and you will sort of bury away and push away your marginal branch of the marginal mandibular branch. And you can see that here in a much better way. I think here's the nerve, and here's the facial vessels. So if you stay as low as possible on those vessels, you will not be into trouble at all. Now another one is the accessory nerve, and that is a nerve that suffers greatly during lateral dissections, level 5 obviously, level 5B, which is cranially bordered by the spinal accessory nerve, and that is a nerve to be a little bit concerned about. It's probably the one most commonly injured during lateral neck dissections. And when you raise the posterior triangle skin flap, be not surprised to find it early, because it runs surprisingly superficial than you would expect from the anatomical images. It lies, if you want to start posteriorly on the sternocleidomastoid muscle, it lies about a centimeter above Erb's point, with of course all sorts of variation. But you can also injure it high up in the neck, where it runs really parallel to the internal jugular vein before it enters into or under the sternocleidomastoid muscle to go to lateral. It is not often necessary due to tumor extension. There are exceptions, but generally you can save the nerve by carefully dissecting it all free. And it's hardly ever necessary to deliberately sacrifice it because of tumor invasion, but sometimes there are exceptions to that rule. The same goes for the phrenic nerve, which to in my experience is very easy to preserve, generally speaking. It lies deep, right onto the scalenus anterior muscle, and with generally with some blunt dissection, and pulling the nose and the areolar tissue up into the operating field and in the operating vision, you can easily push down the nerve and preserve it that way. So in conclusion, I think the treatment of particularly of well-differentiated thyroid cancer, which is the vast majority of cases, rarely necessitates sacrificing of major structures. The preparation is not only on the team, the colleagues, the OR personnel, but particularly also on the patient and his or her family. Don't be in a rush. Use magnifying glasses, and in complex cases, team up with 2 surgeons. And I extend my gratitude also to my colleague of last year, Ming, who is here on the picture taken in Sabah, the delightful conference with that. I'll be happy to take this.
Thank you, Prof. Any questions from the floor?